Just as a bit of background, my primary background is in cerebrovascular disease imaging and looking at blood flow. And I used to carpool to work with my wife, who was a lymphedema therapist, and she'd always told me that you should look at the lymphatics, and I kind of zoned her out for a while. And then eventually I thought that we could do this, and so now for the last 5 years or so, we've actually had a pretty big research program translating methods that we've been optimizing for looking at blood flow to looking at lymphatic flow. And I was asked today to talk about emerging MRI techniques for lymphedema diagnosis. And just some disclosure, so this is our funding sources, and then we also provide some healthcare consulting services. And an outline for this talk, and sort of the main idea is sort of, why do you want to use magnetic resonance imaging to visualize lymphatic dysfunction? What a lot of people will say is, well, look at advancing stages of disease with lymphedema, you have limb swelling, tissue fibrosis, those are clinical indicators. You really just need a tape measure to diagnose that. But the way that we think about it is there are also subclinical indicators of disease. So you first get things like lymph stasis, and then changes in the molecular microenvironment, fat deposition potentially. And if you can detect lymphedema at those stages, then you can potentially triage those patients for prophylactic therapies and that sort of thing before you get irreversible tissue damage. So in principle, MR has relevance for in the clinical stages for diagnosis, but also for developing sensitive biomarkers to evaluate new therapies. So those could be PT or pharmacological or surgery. Then also maybe for predicting progression in early stages, if we can sensitize our sequences to some of these parameters. And then for things like secondary lymphedema, you can also imagine prevention. So identifying lymph nodes that are malignant versus benign, and then just making sure that you only remove what you have to remove. And MRI is actually very good for this. So it's a very versatile way of looking at soft tissue structure. And if you're not familiar with MR and the different imaging techniques, the one thing that I would emphasize that's a strength of MR is that it's a non-invasive method, so you don't necessarily have to inject anything, although you can. And it doesn't require any ionizing radiation. So you're getting exposed to the same amount of radiation that you're getting exposed to right here. And just by being a little bit clever and changing when you turn it on and off the magnetic field or change it, and when you apply different radio frequency pulses, you can sensitize your sequence to very different contrasts. In just a couple minutes, you can get, you can visualize the lymph nodes. You can do higher spatial resolution imaging of the fat and the water, also looking at subcutaneous edema and that sort of thing. And we're also trying to look at lymph vessels. I'm actually not using principles of tracer methods like you've heard in the past couple slides, which are very nice, but also much more quickly, just using different diffusion principles and that sort of thing. So at our center, what we've done, so we're now in the 4th or 5th year of an 8-year clinical trial, which we've called INFORM. So this is funded by the National Institute of Nursing Research, and it stands for Imaging Non-Invasively with Functional MRI for Onset, it stands for Onset, Response, and Management of Lymphatic Impairment. And the idea with this is, first what we're doing is we're developing MRI techniques to evaluate lymphatic function. So we bring in patients that have advanced stage lymphedema, and then we validate the contrast that we're trying to work on developing in those patients. So we have patients that we have known deficiencies. And then what we're doing now is we're scanning patients before and after lymph node dissection, so sort of in subclinical stages of disease, also at risk. And then we monitor those patients for several years to see which ones of them develop lymphedema, then to go back and see whether any of those novel imaging methods provided prognostic indicators. So we have support from physical therapy, so Paula Donahue, imaging, so this is our postdoctoral fellow, Rochelle Crescenzi, clinical trials coordination, also pharmacology. We also have support from radiology and surgery as well. So how do we go about doing this? And I'm just going to start very briefly by taking everyone back to the fact that MR imaging in the lymphatic system is very primitive, actually. So you've heard from some experts here, but most people don't do this routinely. And if you do this at very high field, this is sort of the anatomy of a lymph node. We've heard a bit about this today. I won't go into it again. But if you go to very high magnetic field strength, like 7 Tesla, so most MR scanners in the clinic are 1.5T or 3T. You can look at like the different structures of the lymph node, the hilum, the cortex, different afferent, efferent vessels coming in. You can do this at pretty high spatial resolution, so 180 microns or so, but the scan time is really long, so it's like 5 hours or so. So this is ex vivo, so that's a bit long for a patient. So what we're working on is, can we get nice in contrast as well, in a more feasible scan time? And to do this, really what you need to know is just some basic parameters about how water in lymph nodes behaves in a magnetic field, and we actually don't know that from the literature. So the first thing that we set out to do was just to do something very basic, which is measuring things called the T1 and the T2, also the T1 row for the MR people, in different lymphatic structures. So if you know this information, as you heard a little bit about in the last talk, then it allows you to really optimize anatomical imaging and also functional imaging to look at different lymphatic structures. So the first thing that we did is we went through and we scanned a bunch of people, and we looked at measuring these fundamental MRI parameters in the hilum, the cortex, the medulla, also in lymphatic fluid and blood. And again, that's relevant for developing optimal protocols. And I'll also talk, it's also relevant for sort of developing new methods that are sort of functional. So the way that we do this is similar as before. So you have sort of a torso coil that we use, and then these are the scan parameters that we use to quantify the T1. So this is one of the relaxation times that's relevant, and then the T2 as well. And then we do this in the axillary lymph nodes to begin with. And then we have good support. So Shelley actually went through and she drew regions on about 105 lymph nodes with supportive radiology. So she wasn't too happy about that. But so it took a couple of years. But now we have nice information in terms of what the relaxation times are and things like the cortex, the fatty hilum, also different vessels. And the results that she got from this are listed here. So these are probably not that interesting to most people. They're just numbers. But what I would emphasize is that the MR systems that ship with most of the vendors, they don't have standard protocols for imaging the lymphatics. So if you want to look at the lymphatic structures, you really need to know what these parameters are, and it allows you to guide your sequences. So that's what we've done. So if you look at your magnetization, sort of in the longitudinal plane versus time, so after you prepare your magnetization, how it recovers back to its equilibrium state, that happens at different times for different structures. And that's what allows you to get contrast. So if you want to see contrast between two structures, then you pick your sort of imaging time at a certain time. And then we've reported sort of what the actual optimal parameters are for things like if you want to look at fatty hilum, or fat versus hilum, or fat versus muscle, and so forth in a T1 weighted sequence. And then you can do the same thing in a T2 weighted sequence. These are sort of optimal echo times for doing T2 weighted anatomical imaging. And just as an example of how this looks, when you use sort of the optimal parameters, this is a T1 weighted non-fat sat image looking at lymph nodes, and then with fat sat sort of using different parameters that are optimized for different substructures. And then, if you want to look at like lymph versus hilum, for instance, you can actually do this here. So you see good contrast between like the hilum and then a vessel that's coming in there. So within our protocols now, we do a T1 weighted fat sat and non-fat sat, and then a T2 weighted fat sat sort of with these optimal parameters. So that's kind of a brief intro to sort of how we got started with this. But anatomical imaging, especially for MR people, that's still a little bit basic. So the question is, can we use some of these principles to look at more complex things, like maybe the chemical environment or so forth? And so just a little bit of chemistry. If you look at a peptide backbone, it looks something like this. This is your peptide bond and so forth. And different protons that are on the peptide or the macromolecule will resonate or spin in the magnetic scanner at different frequencies. Like your aliphatic protons that are tied to carbons, they have a certain resonance. Aromatic protons are a little bit different. And then exchangeable protons. These are protons that are actually labeled, so they can move from the molecule onto like water, and they resonate at a different frequency as well. So they're all kind of spinning at a different frequency. And we can't image these protons directly, I would say. We almost always, with MRI, we image water. And the reason is because the relaxation times and the signal that we get from these is just really small. But you can imagine that if you could look at if you could look at like protein content, that would be relevant to like interstitial protein accumulation, that sort of thing. It might be relevant to CEST. So one of the things that we've been, relevant to lymphedema. So one of the things that we've been looking at is, can we measure sort of this interstitial protein accumulation as kind of a surrogate marker of lymphatic dysfunction. And so how do you do that? So like I said, with MRI, you almost always measure the water signal. So what we do with this is, before we measure the water signal, we apply another radio frequency pulse that's sort of at exactly the resonance frequency of these amide protons that are on interstitial proteins. And what will happen is that amide proton will take some of that energy, and then that proton will physically exchange with the water, and it'll reduce the water signal where that happens. And that's what I've written right here. So you magnetically you sort of stimulate this amide proton, you then wait a little bit of time for it to move onto the water, and then that water signal will reduce. And the amount that water signal reduces tells you something about how much of that protein is there. And the way that you do this in principle is you kind of have your water signal that you usually image. And before that, you can apply a pulse that's really far away from the water resonance at a really different frequency. That doesn't have much effect on the water signal. And then if you put that off-resonance pulse right on sort of one of these exchanging protons, then that proton will exchange and will reduce your water signal. You can measure that. And then usually we sweep kind of all the way through, so then we apply another resonance kind of closer to the water. Now the water goes down a little bit, and that's mostly because this pulse isn't perfect, so we hit a little bit of the water, but it's not due to exchange. Then if we go right on the water resonance, then we totally crush it out. So this is kind of how we do this experiment, by applying these different pre-pulses before we detect our water signal. And when you do this is just an example of what this looks like in a healthy control in a lymphedema patient. So this is a control, just kind of the region that we're looking at through the axilla here. And then if you look at this sort of protein-weighted signal in the healthy control in this spectrum, so this is kind of the signal that you get for these different resonance frequencies. And these interstitial proteins, they kind of resonate right around at 3.5 ppm. And you see that it's pretty symmetric here. You don't see many bumps either on the right or the left side. Then if you go to patients, this is actually interesting. This is a stage 0 patient, scanned about a month after dissection. They had 14 lymph nodes removed, but they were stage 0. And you can see already in this early time period after the surgery that there's a lot of asymmetry between the different arms. If you look right where these interstitial proteins should resonate, then you see there's a lot of bumps here, and that's due to more protein that's accumulating on the affected side. So this potentially could be a way not to look at lymphatics directly, but to look at the locus of interstitial protein accumulation. And we've done this now in a small study series of controls, and if you look at this protein-weighted signal, it doesn't vary between the right and the left side. Also, if you look at a line graph, and then when you look at the patients, on the lymphedema side, we have sort of a higher protein-weighted signal than on the other side. And you see that sort of on an individual case basis as well. What you can also do with this is not just look at where the lymphedema or where the proteins are accumulating, but you can use it as sort of a biomarker to evaluate therapy. So this is what we've been doing now with manual lymphatic drainage therapy. And we heard a little bit about this today. There's still some controversy as to whether this works or not. And part of the problems was sort of validating that is, how do you validate it? Well, the patient feels better. Maybe you do a tape measure, LDEX, parameter, TDC, but all those things actually aren't terribly sensitive to one session of MLD. So what we do here is we look at, this is a patient before, stage 2, before MLD. We scan them, and then they go in and they get a 1-hour MLD session by a physical therapist. And then you scan them again, and you can see that there's sort of evidence of this CEST contrast, or this protein contrast changing immediately after MLD. So we're now doing a crossover trial looking at sort of sham interventions along with MLD, and sort of this negative pressure therapy as well to see whether we can look at effects of this. And if you can show that, then you can show that these therapies work. And it's also relevant if you want to look at pharmacological therapies or even surgical therapies, that sort of thing. And then one thing before going on to the last part is that in addition to looking at patients with lymphedema, really if you want to reduce lymphedema burden, you want to reduce people from getting it in the first place. So these CEST sequences that we're looking at are not just sensitive to interstitial protein accumulation after the fact, they might also be sensitive to cancer metastases in lymph nodes. So this is just an example of this spectrum again that I showed before. So this is sort of the signal that you measure when you sweep through different frequencies, and we have this protein accumulation signal that occurs here. And lots of times you'll also have this other dip at about, on the other side of the spectrum, about 2 to 3 ppm or so. And that's due to this nuclear Overhauser effect. And if you're unfamiliar with the nuclear Overhauser effect, like most reasonable people, I would say, then that is an effect in which protons, unlike aliphatic protons, can absorb energy, and then they can move that energy through cross-relaxation to other protons, and then those protons can exchange with water. So it's just another sort of exchange mechanism. And that's been shown to be different in cancers and tumors and that sort of thing. So what we did here is we looked at what happens if you look at malignant lymph nodes confirmed by biopsy versus benign lymph nodes before you do the dissection at all. And here what you see, if you look at your interstitial protein accumulation in the actual lymph nodes and not in the tissue, that's higher. Also, this nuclear Overhauser effect is higher. And then the T2 that you measure, sort of this water relaxation environment parameter, is a little bit lower. So what we're trying to do now is see whether you can actually map these onto the lymph nodes. You can do high-resolution lymph node imaging, and then you can measure what's going on in terms of these chemical exchange effects in the different lymph nodes, and you can color code them based on whether you think they're benign or whether they're malignant. And now we're looking at whether you can validate that with biopsy and that sort of thing. So, and if you could do something like this, it would be a non-invasive way of looking at cancer metastasis in the lymph nodes, which would be able to guide surgeons to just remove lymph nodes that need to be that are malignant. And then just in the last couple minutes, I want to talk about looking at mechanisms and that sort of thing with some of the new imaging sequences. And this is not our work, but this is a nice work in animals where they fed the animals a low-salt diet or a high-salt diet. And then they looked at what happened to things like the sodium in the skin. And they found in the low-salt diet animals, they had much lower sodium that accumulated in the skin than in the high-salt diet. And what they also found is that this sort of evidence of lymphatic hypertrophy. So the lymphatic vessels are also a little bit enlarged in the people or in the mice that had the high-salt diet. So this provides some evidence from the animal literature, and there's other evidence as well, linking lymphatic dysfunction potentially with sodium accumulation. And there's also evidence in terms of knockout studies in which you can knock out for these sort of PROX1 genes. These are reporter genes for lymphatics. And when you do that, the mice develop an obese phenotype. So if you knock out these sort of abilities to develop the lymphatics in this way, then you'll develop sort of a fatter mouse than a wild-type mouse. So this links potentially lymphatic function with adipose and fat accumulation as well. So what we're interested in looking at now is whether we can measure these things in vivo as well and get more information on the mechanism of why different patients, sort of what the link is between fat, lymphatics, and possibly sodium as well. And so we do whole body fat water imaging now. So you heard a little bit about this mDixon method in the last talk. So that we can do this now. There's sliding bed technology with MRI scanners. So you can actually slide the patient through. It takes about 7 minutes to do the whole body. And you can look at the fat in the water. So the fat is bright here, and then the water is hypointense. And I love this slide, actually. So this is a female control. This is a lipedema patient. This is a metabolic fat disorder that doesn't respond to diet and exercise. We also study a lot of these patients. And then this is a lymphedema patient. And what's interesting about this is that they all have pretty much the same BMI, right? So it's right around 25 or so. But then if you look at what's going on with the fat water in their body, so this is the control. So the fat is bright. Can you see it? This is the lipedema patients. They got a lot of fat. And then this is the lymphedema patient. And they're somewhere in between. So just looking, we heard about this earlier today as well with a nice BMI talk, but just measuring BMI or looking at external parameters doesn't give you nearly as much information about sort of how the fat is accumulated in the body and what that might mean. Okay, so what does that mean in terms of lymphatics? Well, if you do these lymphangiography methods as well, you can look at a patient. So this is actually a lipedema patient, stage 1, so early stage, and they have a little bit of lymph stasis and some that you can see here. And then if you look at someone that's much more advanced, also that has a much higher fat content, then you see potential evidence of lymph stasis as well, so lymphatic dysfunction. And what's interesting, if you look at the sodium in these people as well, so this is a lymphatic patient or a stage 3 lymphedema patient, and you look at the affected side, so this is unilateral lower extremity lymphedema, they have much higher sodium, so you can measure sodium with MRI as well using a different coil. And then if you look at the contralateral leg, it looks something like this, so they don't have nearly as much sodium. This looks more like a control. This is a really extreme case, I would say, but we do usually see about 10 to 20% elevation in sodium in patients with lymphedema as well. So we're trying to look at now mechanisms in terms of how sodium accumulates in the subcutaneous tissue in the skin and how that relates to adipose deposition and also to lymphatic dysfunction. And that's relevant for lymphedema potentially, but also for all sorts of fat disorders and even salt-sensitive hypertension and that sort of thing. And then just some interim findings in the last slide in terms of the conclusions of our sort of ongoing trial, patients that we're sort of monitoring. So if you look at sort of commonly reported risk factors in patients that don't progress at follow-up versus patients that do progress at follow-up after axillary lymph node dissection, things like the number of lymph nodes removed, the BMI, arm volume, asymmetry, age, all these things are a little bit elevated in those that do progress, and that's kind of known. But none of these things are significant so far with our sample size anyway. So it's kind of a weak but non-definitive indicator. And then some of the new MR methods that we're looking at, so things like looking at the sort of quantitative fat-water ratio and also sort of the environment in terms of the water microenvironment with the T2. Those things also aren't quite significant yet, but they're trending much more significant than these things. So we think that we might have some promising indicators using MRI of new parameters that can predict progression. And that's kind of the goal of our work, I would say. All right, so just in conclusion, so MRI provides a relatively versatile and non-invasive tool to visualize soft tissue and lymphatic anatomy. And you don't need to inject anything necessarily. And all the scan times are generally less than an hour. That's relevant in multiple stages of lymphatic disorder. So you can look at prevention, identifying candidate lymph nodes for dissection, evaluating therapies, and then also for prognosis. So what we've done is we've quantified these sort of MRI relaxation times that lets you get good anatomical contrast of the lymph node and the different substructures. We also look at imaging the chemical environment with the CEST technique, and that gives you a measure of potentially node malignancy, but also edema and protein accumulation. And then also multinuclear MRI, so looking at things like sodium, might provide interesting insights between adipose accumulation, lymphatic function, and potentially sodium, and that sort of thing. So that's what we're working on. And these are the people that did the work. So mostly Shelley Crescenzi here and Paula Donahue are the ones that did most of the work.